Okay, hello everybody. We are going to be covering chapter 15. As I mentioned in your announcements on Canvas, you are going to be independently reviewing chapter 14. There are a lot of details about specific needs of specific religions. I did not feel like it would be helpful if I read off of those slides because it really would have been me reading off of all of those slides and not providing too much insight because every religion is very detailed, expansive. Some of those cultural practices are actually outdated, I would say, or sometimes they're not super accurate. I think the goal that you want to focus on for chapter 14 is that there are differences between cultures and religions. You want to make sure as a nurse you're always assessing what each patient needs from you. Just because somebody identifies as Catholic doesn't mean that they follow along with all of the rules that Catholicism promotes or experiences. So I think really read through the slides, of course. You still want to read through every single slide and note down anything that you find significant. If there are religions that you encounter in the slides that don't allow certain things, for example, Jehovah's Witnesses, traditionally, they do not allow to receive blood products. Those are the details that are important. On the other hand, though, there were a lot of religions that chapter covered. Of course, you will not be able to memorize and remember all of these things. You are a nurse. I want you guys to focus on the nursing side of it and prioritize in those slides what you feel like would be important. I created a study guide. Of course, as I said, these study guides are used as guides. It's not used as your learning tool. It does not replace watching lectures at all or attending lectures at all, and it will not cover everything. So just be very mindful of that. You will still need to read your textbooks and you will still need to read your slides. You will still need to do active assignment participation and then just listen in discussions. So we're just going to jump right in. So as I said, we're beginning on chapter 15 now. It's loss, grief, and end of life care. You will experience death while you are working as a nurse, of course. So in my experience as a floor nurse in long-term care only, I had 5 patients that I grew very intimate relationships with, especially when you're in long-term care, you really grow to care for that person and be very involved in their routine. I had about 5 patients as I took care of them pass away, which is natural. But it is something that we still experience for ourselves, the grieving process. And then you will also see too, sometimes death can be dragged out. So you will see that patient grieve in front of you. And sometimes death is a little bit more sudden or startling. So sometimes you don't get that opportunity to see what the patient is experiencing emotion-wise. Um, so we'll just jump right in and we'll see what the slides are informing us today. And of course, I figured out how to do Zoom a little bit better. So I'm on the screen this time, and I believe the PowerPoints are this way. I hope that you guys are able to read. If not, I want you guys to at least follow along with your slides. I don't know if this will come out crystal clear. So please just make sure on your own end you have your slides pulled up. Okay, so the objectives here for the overview of loss and grief. For theory, which is your lecture side, you want to make sure that you correlate the stages of grief and of dying with their associated behaviors and feelings. Discuss the concept of hospice care. Identify three common fears a patient is likely to experience when dying. In clinical, you want to be able to apply this. So my Thursday group, you would want to try to familiarize yourself with this. And Friday group, of course, you also want to make sure you're hitting these objectives. You are going to want to identify ways in which you can support or instill hope in the terminally ill patient and his family. Number 2, demonstrate compassionate therapeutic communication techniques with a terminally ill patient and or his family. And I think it's kind of interesting to see in this slide, it's saying that we're going to instill hope. And then, as we had discussed in one of the previous chapters of this week, is you also don't want to provide false reassurance. So As nurses, we're going to have to find a balance between hope, but also a balance of reality and uncertainty at times. So, nurses' attitudes towards end of life care. Death is a universally shared event, with all cultures and religions having beliefs and rituals to explain and cope with death, loss, and grief. It is still taboo to have discussions about death in mainstream North American cultures. It is normal for nurses to have difficulty dealing with death and dying, even if they provide care to critically ill or dying patients. I'm sure a lot of us, if not some of us, have experienced death in the family. So we can be sensitive or have some type of background knowledge of how it is painful. It's not an easy process. And you also might be surprised as a nurse how much your patient's death would affect you. So I found it interesting, the slide that it said that even in North American cultures, death is taboo. I think that is kind of true for maybe a lot of cultures, but if not, it would be interesting to know if any of you guys have any thing you want to add or mention in the group chat or comment on an announcement to say what it's like in your culture. That would be kind of interesting to know. And as it said, it is normal for nurses to have difficulty dealing with that. So a lot of people think that because we are experienced professionals, we will be flat in our expressions of when something like this happens. And some nurses actually do turn to those emotions, and maybe it is from burnout or it's from experiencing this frequently. But a lot of the times, like I said, nurses will still definitely have a lot of grief with this as well, which is completely normal. It's human for you to experience this, it's normal. Um, and it's natural to feel like you are grieving alongside with a patient's family member or just amongst your nursing team. Um, so there are a lot of phrases that we can think of when it comes to a person experiencing death. I think in different cultures or different even households, there are phrases that we use that can be differently than other people. Some people like to say passed on, or some people like to say they are in heaven, or some people like to say um, they've crossed the other side. There's a lot of different languages to explain that death has occurred. You always want to make sure that you are sensitive to however somebody presents this phrase, especially if it is the patient's family or anybody involved in their immediate care. Sensitive in the fact that you will understand that for some people, grieving also incorporates humor, which might be shocking for some people, but that is just how some people process, and that is also okay. As a nurse, you want to be professional with how you interact with this subject, but you also want to be validating. So if somebody experiences death in a very humorous way, that might be unfamiliar for us, but as I said, we just kind of have to understand and be there and support. And it doesn't mean you have to laugh with them, but it's something that you have to at least be able to tolerate in general. Um, there are many personal challenges when you are caring for somebody dying. As you can imagine, I think there's a lot of things that can come up for you if you take a second to think about it. What would it be that would be challenging for you if you are a nurse, you are on the floor, and you are taking care of somebody that you know is going to die? That is not easy. Um, it's a concept that I think that is very difficult, really. Like I said, if I'm bringing up my personal current experience, I work with a lot of children and young adults and college age students who attempt to um, suicide. So I'm constantly in those crisis emotions with these patients, and I'm constantly there to support them. But in some ways, it sometimes still really spooks me that the patient in front of me, even though they are an adorable kid or a very intelligent young college student, they have attempted, and that is, a process of them attempting to die. And for me, that is still something that spooks me out. Um, and it's okay for you to feel that way if that is a situation that does come up for you. Everybody grieves differently and everybody processes differently. So do what is appropriate for you, but always make sure that you are still moving in the best intention for your patient as well as the patient's family or anybody that is involved at that time. So change. Loss, grief, and mourning have been described as experiences intrinsically linked with life changes. These are normal and inevitable life transitions over the lifespan. Family therapist Virginia Satir identified the following 6 stages people experience when experiencing life changes: status quo, introduction of a foreign element, chaos, integration, practice, new status quo. Loss. To no longer possess or have an object, person, or situation. It can be physical, like a loss of a limb or a body function. So I think this is a great bullet point to kind of pause at and reflect. At the beginning of this lecture, we've mainly focused on death, but loss can, of course, be just as it says, no longer possess or have something that you used to have. So it doesn't always have to be death. It can be a loss of a limb. For a lot of older adults, loss of hearing is very distressful for them. Loss of their motor abilities, being able to walk as fast, being able to process as fast. This also elicits a lot of grief. So grief and loss, of course, it comes with other situations beyond death. So I think this is kind of a good reminder also for me that it's not always focused about death. Loss also can be in reference to anything else that was once there and gone. Psychosocial, loss of a loved one. That is what we've really been focusing so far. And only the person experiencing the loss can define the value of the loss. So those who are involved have that podium, if you will, to describe what they're feeling. You want to be able to allow them to have that space to speak about it. You're going to probably be working in communal spaces, so you will have other residents or other patients that will experience this grief and express about this grief as well. Maybe they lost a resident that was one of their best friends that they would play like bingo with. So it's not just family that experiences loss, it's also the nurse itself, the healthcare team, as well as other residents, patients, and other people that were involved as well. Loss is, of course, very deeply personal. There's a lot of value attached to this. It's a complex topic. It's not a one size fits all, and it does just look differently for everybody. Grief, the total emotional feeling of pain and distress that a person experiences as a reaction to loss. Grieving process, it occurs over time. A person adapts and moves through pain and associated symptoms toward recovery or acceptance. Bereavement, the state of having suffered a loss by death. Grieving person may experience physical and emotional symptoms. Persons who are dying, as well as their loved ones, experience loss and grief when faced with a terminal diagnosis. So we'll touch on the slide a little bit. Grieving person may experience physical and emotional symptoms. So beyond somebody feeling sad, maybe somebody's feeling tired as they're grieving, somebody's feeling anxious as they're grieving. Of course, there can be a lot of physical changes that you will see in a grieving person. Physical changes that I can think of right off the top of my head, somebody who's grieving may experience hair loss from stress. Physical experiences as well include weight loss. It can also be weight gain for grief. I want you guys to also take a second. We'll give you a little 10-second break right now so that you can think of in your head how would somebody experience physical and emotional symptoms? I want you to compare and contrast that. And I think that that has value for our discussion. So I think that's something that you should write down or reflect on. So I'm going to give you guys 10 seconds. Okay, so hopefully you guys thought of something that you can identify as both physical and then also an emotional symptom of grieving. I also want to touch on what I had mentioned. So, someone can already experience loss and grief when faced with a terminal diagnosis. As I have shared for my personal experience, this was true for me. When I had my mom be diagnosed with cancer, for me, I felt that my grieving process began at that moment. Um, and what was interesting for a lot of people, and also something that was shocking for myself, was by the time my mom had passed, I didn't really realize that I was grieving in the moment. Of course, I knew I was sad and I knew I would miss my mother, of course, but in the moment, it was hard for me to realize that I had already started that process. By the time my mom had passed, I actually was okay. And I think that surprised myself, and I think that maybe surprised others as well. But I think that it does make a great point that loss and grief happen sometimes for people at the beginning of a terminal diagnosis. And sometimes after that person passes, that duration of your grief and loss accounts for a lot of time. And by the time you get to the point where that person has passed, you might not feel those feelings as strongly as you might have anticipated you would have. Okay. So, grief, there's an anticipatory grieving. This may occur before the loss actually happens. So, I just spoke about that. And then dysfunctional grieving, it falls outside normal responses. Dysfunctional. Prolonged grieving, person seems trapped in a stage, unable to progress. Visible absence of grieving may be viewed by others as a good adjustment, but it often results in later psychosomatic illness. Um, so yeah, I think what I had just said out loud was valuable. So sometimes, although somebody may seem that they have adjusted well or things are going okay, you can kind of think of the quote that people say, the body takes count or the body remembers. So, although you may psychologically be okay, you may notice that you are getting maybe sick or you are feeling a lot of body experiences because your mind is being able to tolerate these concepts, but your body is not. Um, Anticipatory grieving, I just spoke about that and I gave a real life example. Dysfunctional grieving, this falls outside of normal responses. Um, so this is pretty much saying that the person is not responding to this grief in an appropriate way. Um, what I can think about that, or an example I can give you guys for that, is if somebody becomes suicidal after they are grieving, or somebody completely destroys their life after or when they begin to grieve. These are things that are out of the normal. They are not normal responses. That person also may need some support. Prolonged grieving refers to not being able to move on, especially after a certain amount of time has been given to you and you've spent some time reflecting and processing. Some people are unable to get out of that cycle. It doesn't mean that because you think about the person that has passed here and there, you are in a prolonged grieving stage. That is not what that means. It's referring to somebody who is having an unhealthy experience and feeling trapped. Symptoms of grief. depression, sadness, fatigue, apathy, lack of interest, sleep alterations, loss of appetite, change in sexual interest, anxiety, shortness of breath, feeling hopeless, helpless, restless, angry, irritable. So, of course, as I said, not everybody experiences these symptoms, and it also depends on where they are at with their grieving process. Um, and grieving symptoms, they are not happening in this exact order. They can happen in different orders, and they can also happen in different times. Forgetfulness, tendency to make mistakes, confusion, disorientation, symptoms of the same illness the deceased suffered. Seeing loved one's presence, hearing loved one's voice, need to tell and retell things about the loved one. So, um, as a nurse, of course, one of your main duties and main responsibilities is to be an empathetic person. So especially when it comes to grief, this is not something that you want to rush. You always want to allow um, this person to feel heard. So stages of grief: disbelief, yearning, anger, depression, and acceptance peak within 6 months after the loss. Nurse should reevaluate and create additional nursing plans for patients who continue to score high in these areas after 6 months. Excuse me. You can assist persons who are grieving by accepting their feelings, of course, and their behaviors, and you, of course, want to validate their loss. You don't pretend like it doesn't happen. I think that, of course, is uncomfortable for a lot of people, but you do not want to avoid that this ever happened. Yeah, do not act like it doesn't exist. Don't try to avoid it because it makes you feel uncomfortable, nothing like that. So how would you, as a nurse, validate the loss of a grieving person? You want to reassure them, of course. They need to feel important and that what they are saying is important and understood. You want to remove any environmental distractions. So if you are in the patient's room and the TV is on very loud, turn it down, assess your situation, make sure that where you are is an appropriate place and environment and space for this person to express how they feel. Um, and you want to have concern, genuine concern for whoever is speaking about this, and you want to be supportive. Death and dying. Sorry, guys, my nose is itchy. Death and dying. Death as a physiologic event is typically defined by the absence of spontaneous breathing and heartbeat. The definition of death is now centered on the concept of brain death, which is defined as the absence of brain activity as evidenced by the absence of an ECG wave. Brain death is characterized by three cardinal findings: coma, absence of brainstem reflexes, and apnea. I think that this is valuable, so I want you guys to either write down right now what the definition of death is, how a nurse would be able to identify this, and what is the procedure that is evidence that death has occurred. So take a second to write this down or note it somewhere or star this. I would also like you guys to write down what brain death is characterized and the three cardinal findings. If you do not know what a coma is, I want you to look that up. If you do not understand the concept of brainstem reflexes, I would also like you to look that up, and same with apnea. Standards of care for the terminally ill. Opportunities provided to spend final moments with people important to the patient. Families will have opportunity to discuss the patient's imminent death with staff. Family provided private time with the patient. Family will be provided time to carry out cultural customs regarding the body after death. So when we are communicating in a situation where we are taking care of somebody who is terminally ill, of course, you want to communicate, as we've discussed the different styles of communication, you want to be communicating in a therapeutic way, which would be open-ended questions. So open-ended questions refers to you being curious, you allowing and encouraging verbalization. So if I'm asking just closed questions, yes or no questions to somebody who is terminally ill, it is not giving off the sensation that I actually genuinely care. You want to also see as a nurse if there are any cultural customs that will be carried out or any cultural customs that they need you to be sensitive to. There are a lot of cultures that will have their own practices and customs that you might need to be aware of as a nurse prior to that so that you are prepared. So, of course, a lot of these subjects and these concepts is very sensitive. You need to work on the communication that we have talked about in the previous chapter and the way that would be most therapeutic for somebody who is receiving this information. So, end of life care within the healthcare system. Consider the terminally ill patient's preferences. Try to maintain functional capacity and relieve discomfort. Control patient's pain. Be aware of advanced directives and durable powers of attorney. Make the patient feel safe and secure. The patient will have ample opportunity to finish business with loved ones. So take a second to now think about what you would feel for a patient if they said they wanted to refuse life-saving treatments. Take a second and think about how that would make you feel. So now I want you to also then consider how it would make you feel if this is maybe a family friend or a family member or a friend or a coworker. How would that make you feel? Some people are okay with it. Some people feel uncomfortable with this idea. Um, we just have to respect what people's wishes are, and they will not always be our wishes, and maybe they don't align with our values or what we feel like would be best, but this is ultimately their choice and their right as the patient. And just because I disagree with it or agree with it, it doesn't really matter. The nurse's role is to be there to support. Um, What's most important for a nurse, and you will see this in real world nursing, is you need to control that patient's pain. You do not want your patient to go in distress. You don't want to make it any more difficult for them. So, as a nurse, you will be given that right to medicate a patient, and it will be your call. Unless, of course, a doctor has standard orders, which means that you will be giving pain medication at a certain time. Otherwise, um, a lot of nurses get the opportunity to administer as needed medications. We call these PRN medications. And these medications are offered to control pain. You want to see the nonverbal cues as well as verbal cues to see whether or not the patient needs to be medicated for pain. Another very important bullet point here is to be aware of advanced directives and durable powers of attorney. So if they have any of these in place, you need to make sure that you know that, especially if you are dealing with somebody who is at the end of their life. These directives are in place as well as a power of attorney to make and supersede specific medical decisions and choices. So you want to make sure that you are aware of who you would need to turn to. You want to make sure that the patient feels safe and secure. Um, so that also means, like I said, kind of respecting what they have decided. Rights of the patient dying. A person who is dying has the right to be treated as a person until death. Caring human contact. Have pain controlled, cleanliness and comfort. Maintain a sense of hope. Participate in his care or the planning of it. Respectful, caring, medical, and nursing attention. Um, as I just mentioned in the last slide, it's really important in the topic of a dying patient or a patient that is severely sick. You always want to make sure as the nurse you are assessing for those nonverbal cues, which would suggest to you either pain, anxiety, discomfort of any kind. And you also want to take note on the slide, just because somebody is dying does not mean that they will not receive care. And that might sound like a very obvious comment, but you may see in the nursing field, some people or some nurses, I will say, give up, as well as family members can give up. Even the patient will give up. Um, but that is negligence, actually. So you are still expected to take care of a patient. So if that patient needs their wound dressings clean, they need that still to be done. If they need to be turned every few hours, that still needs to be done. They need to be clean and they need to be comfortable. There are tasks that you might complete or are expected to complete as a nurse that you will feel like this is making them feel worse. This is causing them too much distress. But a lot of these tasks, especially if a doctor is ordering these tasks, these are still in your right to perform, even if we feel that it might be distressing to a patient. We still want to respect their dignity and make sure that they are still being taken care of by a medical professional. Rights of the patient dying. A person who is dying has the right to continuity of care and caregivers, information about his condition and impending death, honest answers to questions, explore and change religious beliefs, maintain individuality, and express emotions freely without being judged. So, as I said, communication will really come up in every chapter I think that we discuss. You are going to be having difficult and uncomfortable conversations. It is not easy to tell a patient that they are dying, but you will have to do it. It is not easy to tell a patient that they are terminally ill, but you will come across this and you will have to do it. Um, you need to familiarize yourself with what is your most empathetic style of presenting these types of difficult information. Um, but as a nurse, you will experience this and it will happen to you in the span of your career. You are going to be somebody who is typically um, discussing bad news. So it's not easy to do this. This is a skill that's practiced frequently. And as I said, you will have to adjust based on the needs and culture of your patient. You always want to make sure, of course, when you are ever interacting in these scenarios and you are discussing somebody's sensitive circumstances, that you are absolutely only discussing this in a private space. Um, Privacy is really important here. You don't want to be discussing this in front of somebody that they may feel judged in front of, or somebody that they don't want them to know all the details. Of course, when you have a dying patient, a lot of people will come into the hospital or the long-term care facility. They'll be involved in the care. You might think that it's okay for you to say certain things in front of them, but the truth is that every patient is really different. So not all patients want to be discussing the extensive details of what they are going through with others. A person who is dying has the right to make amends and settle personal business, say goodbye to family and significant others in private, assistance for significant others with the grief process, withdraw from social contact if desired, die at home in familiar surroundings, die with dignity, respectful treatment of the body after death. Dying with dignity is an interesting phrase and concept. I touched on this in a couple slides before, but this might mean something different to you, and it does look different to everybody. Some of the basic things that I can think of when I'm thinking of dying with dignity is that patient needs to be clean. That patient should be fed to the best of their ability if they are able to eat. That patient needs to die with dignity, and that also includes you making sure that their death is not painful. That patient needs to be covered, dressed appropriately, and they need to be treated with care, regardless of if we know what their outcome is. Hospice and palliative care. You will want to know the difference between these two. So, palliative care. The goal is to reduce or relieve the symptoms of a disease without attempting to provide a cure. This preserves life while accepting death as a normal and expected outcome. So I'm going to read it one more time. Goal is to reduce or relieve the symptoms of a disease without attempting to provide a cure. Hospice. This is a distinct nursing practice area in which the intent is to help patients in the end stage of life and their families to experience the process of death with the highest quality of life and the least amount of disruption as possible. So some of you might feel confused about what that is. So I want to explain for palliative care, you will still continue to receive treatments. The goal is really to support their quality of life, which can still include medical and surgical interventions. The difference here is the goal of the intervention is not to provide a cure or to recover anything that was lost from this ailment, but to preserve their quality of life, alleviate any type of suffering. The dying process. Some people believe there are distinct stages, while others believe grief is fluid rather than a linear process. Individual's reaction to death may be consistent with the way he coped with the difficulties in the past. Elizabeth Kubler-Ross promoted research into dying and death and identified 5 stages of coping with death. So in the next slide, you're going to see the 5 stages. This is absolutely important, and this is a concept that does come on the NCLEX, so I would review this. This is called the stages of coping with death. Some of you guys may have seen this already, and some of you guys, this is a new concept for you. So we're going to go over it. Number 1 would be denial. So it's that initial shock phase. If you think about somebody that you have lost, you may be able to identify you have felt these emotions. You might feel shocked. You might not believe it. Some people who get that terminally ill diagnosis don't think that it's real. Anger, of course, you are angry. How did this happen? Why did this happen to me? This is not fair. Bargaining. Bargaining is seen pretty often as well. This is when you ask God, please, I need a little bit more. Bargaining with even healthcare professionals. What can I do? Please do this. Please do that. I'll do anything if you can make them stay longer. So you will see this as well, of course. Depression. Then we have acceptance. As I said in a previous slide, people move back and forth between these stages, and sometimes you can get stuck in one of them. Sometimes you recover from a single stage that you're in, and then you return to another. Grieving is very complex, as I've been saying, and it is possible that you move back and forth between the different 5. I want you guys to take a moment to write this down or take a moment to note that you need to come back to this slide. It's really important that you guys understand these 5 stages. Hope in the dying process. Hope is an inner positive life force. It's a feeling that what is desired is possible, takes many forms, and changes as patient declines. At first, there's hope for cure. Then, the hope that treatment will be possible. Next, you'll have a hope for prolonging of life. Finally, hope for a peaceful death. So, when someone gets sick, And initially, a lot of people have that motivation to say, I can do this, I can get through this. Then they realize and start to accept I'm actually sick. Um, that next um, that next feeling would be, I hope that there's at least something possible that I can do for myself that will make this not last too long or that can help me recover. Once we move past that in the dying process and they realize, okay, this is going to happen to me, I hope forms of wanting to at least just sustain life, prolong life. And then finally, once dying kind of continues and begins to escalate in the process, you will see that patients hope for just a peaceful, calm death. And you will see this as a patient begins to accept their fate. As I said, this is not easy. And it doesn't mean that a lot of patients or most patients or some patients will accept that they are dying. Sometimes this does not happen. Um, you want to make sure that you, as I said, have open-ended questions for your patients. You want to be as supportive as possible. So when they're in these different stages of grief, you want to be open-ended in your questions. When you are in these different stages of hope with the dying process, you also want to ask them, what are you hoping for? What do you wish? What can I help you with? If I can make anything easier, what can I do to support you and be there for you? I want to make sure that you feel respected and that you have dignity during this process. What does this seem like it would look like for you? How can I help you achieve your best outcome? So, you want to affirm any of their wishes that they express to you. Of course, the nurse cannot accomplish everything, but anything that they have passed on to you that they are wishing to experience as they are dying is something that you want to make sure that you honor. We're going to be answering some questions now. So we are on a little knowledge check. Hospice is a philosophy of care for the dying patient and the family. Which of the following is not true regarding hospice care? One, it was developed in England in the early 1960s as a reaction to the needs of dying people for care and comfort. Number two, nurses provide around the clock care and relief for families providing terminal care. Number three, hospice was originally a medieval guest house for travelers. And number four, the focus of hospice is rehabilitation. So this is not true. Number four, hospice is not focusing on rehabilitation. It's focusing actually on the acceptance of death as a natural part of your life. The nurse is going to support as a comfort role for both the patient as well as the families. The other answer choices here are true. But yes, we can see and identify the outlier. Say you were taking this test question on the exam. And this will happen on your HESI exam as well as your NCLEX exam. You're going to read a question and you're going to think to yourself, they never went over that because that first question, we never even discussed that in the slides. This is going to happen. And what they're really looking for is for the nurse to critically think, read all of the options. You might not know the truth of the first three choices because maybe you didn't cover that in your studies. But if I'm reading the focus of hospice is rehabilitation, I know for a fact that that was not true. Even if I'm not certain that the other answer choices were true, I know that number four for a fact is not true. That's how I would know that that is the correct answer. I hope that helped you guys. That is one of the study tricks and tips that you guys need to practice. Question two, as a nurse in a hospice setting, it is important to be familiar with the different stages of coping with death as identified by Dr. Kubler-Ross. Kelly goes into her patient's room. Her patient tells her, if I give $10,000 to the Humane Society, then maybe I might live to see my grandson. Which stage of coping is Kelly's patient in? So when you read that question, I'm hoping that you identified or reflected on the fact that you did hear Kubler-Ross in this presentation already. Right when you see that phrase or that doctor's name, you want to recall what are the 5 stages of grief right away. If you did not think of it right away, that's a area where you need to memorize this. Um, so take a look at the question, take a look at the answer choices. I'll give you guys 10 seconds to reflect and think about which one it is. So you should have chose answer number 3. This one I think was kind of easy. It's bargaining. It's somebody saying, if I do this, maybe I might be able to live a little bit longer. Bargaining refers to if I do something good, I will get a reward for this. So just to recap again, I think it's very important that you guys memorize and are able to identify the 5 stages of grief. Do these stages happen in order? And what do all of these stages look like, or what can they look like for a patient? So, lesson 15.2, end of life considerations and preparations. We're going to describe common symptoms related to physiologic changes at the end of life stages. List the common signs of impending death. Illustrate the difference between the patient's right to refuse treatment and assisted suicide. Understand ethical rules in the Code of Ethics for Nurses regarding the patient's right to refuse treatment, euthanasia, and assisted suicide. In clinical, you'll be able to want to describe one nursing intervention for comfort care that can be implemented in a hospital or a nursing home for a dying patient for each of the following problems: pain, nausea, dyspnea, anxiety, constipation, incontinence, thirst, and anorexia. Explain the reason for completing an advance directive to a terminally ill patient, as well as what healthcare proxy and DNI. Prepare to provide information regarding organ or tissue donation in response to family questions, and then assist with postmortem care for a deceased patient. So there was a lot of vocabulary on this slide. So if you read the slide or you listened to me read the slide and you thought to yourself, I don't know what dyspnea is, I need you to look that up. If you are unfamiliar with what an advance directive is, I would also like you guys to look this up. What does DNR mean and what does healthcare proxy mean? Nursing in the dying process, comfort care, you want to identify symptoms that cause the patient distress and adequately treat those symptoms. The application of the nursing process to care of the dying patient uses skills and knowledge from physical, emotional, social, and spiritual contexts. Therapeutic communication is a crucial skill set. How can you address your fear of saying the wrong thing to a dying patient or maybe a family member? You want to be comfortable with your beliefs first, actually. So you want to think about, how do I feel about death? How is that going to make me feel? Whether it is my patient, whether it's my family member, how does death make me feel? Do I get uncomfortable? Do I get comfortable? Am I okay with it? How would I feel if somebody had a different opinion on me when it comes to the dying process? So we need to kind of be accountable and assess our own attitudes about death and dying. Next, you want to be able to feel ready and learn about the actual process of what death looks like. And it's really important to observe experienced nurses talk. Um, so I would, use myself as a reference on how I communicate. I know a lot about communication because, as I said, I work in psych, so I know a lot about how to effectively speak to somebody. You can also take a look at some of your instructors. They are nurses, of course, so they have experience talking to patients and how to manage and navigate difficult conversations, how to navigate somebody bawling their eyes out in front of you, how to control your own emotions. This is really a skill. And this is a skill that you are going to observe by other experienced nurses as well as other healthcare professionals. You need to also be open about your lack of understanding. That way that you can be accountable and learn a little bit more. And you also want to make sure that you are open about discussing patients' feelings and what their needs are. Time and experience are the best teachers for everything, but particularly for this, yes. So, of course, it's just a bunch of reinforcing. A lot of the dying process, the nurse observes through their eyes a lot of the nonverbal communications. So you want to make sure that you are a nurse that is watching and is mindful. Assessment data collection. Baseline assessment and continuing data collection is essential to identifying the problems and needs of patient and family. Pay special attention to assessing pain. Where is the location of the pain? What is the nature of the pain? So nature refers to what does it feel like? Is it aching? Is it stabbing? Is it dull? Is it sharp? What makes it better or worse? This can be different for every single dying patient, and it might not make sense to you, but you will have to be receptive to what is making them feel better or feeling comfortable. You want to also assess their emotional condition. This can often be observed during interaction. You want to also assess anxiety, agitation, confusion, depression may be obvious. Um, you also are going to assess their spirituality, and this can begin with us asking, what is this patient's religion? Would you like to meet with a chaplain? So on and so forth. So this slide is referring to assessment, and in parentheses, you see data collection. So this is data. Data and assessment is referring to things that are observable or come with values or is something that we are able to document on. So this is actually another really important slide. What is able to be assessed in a patient? Nursing diagnosis. So nursing diagnosis for the dying patient will be varied depending on the disease process. Certain nursing diagnoses are common at some point to most dying patients. Planning. Giving the patient control is a first priority at a time when it seems that he has no control. So I'm going to read that again. I think that's a really good, helpful phrase. Giving the patient control is a first priority at a time when it seems that he has no control. So if someone is dying, they already feel like they are at a complete loss. They don't have control of their life. Their life may be crashing down. Things that were easier for them to think about or manage is something that is extremely painful or difficult for them right now. You want to include this patient as much as you can in this care. And some of these patients won't want that, and that is okay, and you need to respect that as well. But if a patient is willing and wants to have any type of control in this process of you planning, you need to honor that. And that is also what incorporates a patient dying with dignity. They will know and feel at peace that they were listened to, they were heard, and their wishes will be respected. Um, Planning should be a team effort with all members of the team aware of the patient's goals and needs. So, what do you guys think would be a rule that maybe need to be assessed by a nurse that should be a little bit more relaxed on a patient who is dying? I want you to take a second and think of that. So, if you're not able to answer it or you need a little bit more insight, I can give you some insight here. As a nurse, you can advocate for your patient to have either restrictive visiting hours, maybe they need more peace, they need more quiet. That's something that they're asking you. And maybe you're able to also advocate for your patient to have extra time with their visitors. You also want to eliminate anything that can be avoided for the patient or that would cause the patient distress, especially if you know that it will not be useful. So in some cases, this can be lab work. So you won't need to draw blood on a patient that you know is going to be expecting death pretty soon. You need to question, is this something that I need to do for my patient? And you can, of course, always ask the provider and say, is this necessary? I don't know if my patient Joe is in the right place to take this on right now. You also want to be flexible with your scheduling. So there are activities of daily living that a patient goes through, and you want to be flexible in this process. If they need extra time, you want to be able to adapt and be sensitive to this. Implementation. Interventions should be implemented for anticipatory guidance, end-stage symptom management, pain control, dyspnea and respiratory distress, constipation, diarrhea, anorexia, nausea, vomiting, and dehydration. So a true nurse studies and learns pain management, and you are going to apply that and use that. Um, as I said, from my experience in real world nursing, pain meds are in the hospital, at least where I work at. It's at the discretion of the nurse to administer. So where I'm working right now, it's in my licensure to administer pain medication to a patient based on my call. So a patient may not always be able to express that they need pain medication. And it's also my job to make sure that I'm looking. So if they have this med available every 6 hours or every 8 hours, I need to hold myself accountable and not expect my patient to be in the role of the nurse. I need to be in the role of the nurse. And I need to make sure that every 8 hours, I'm making sure that I observe and I assess my patient to see, do they need pain medication? Um, you also want to remember at the end of life, you don't want to be concerned about addiction. They're heading towards the end of life. So a lot of these pain medications have addictive qualities to them, but you want to remember and remind yourself, in this situation, a patient's pain and discomfort and their end of life situation supersedes any concern of yours to have that patient be addicted to the medication. It's more important that your patient is comfortable. Implementation interventions should be implemented for delirium, impaired skin integrity, weakness, fatigue, decreased ability to perform activities of daily living, anxiety, depression, agitation, spiritual distress, fear of meaninglessness. So I want you guys to also take a moment to think about pharmacologic interventions. This refers to medications. And then I want you guys to also think about non-pharmacologic interventions. Non-pharmacologic interventions can refer to anything that does not involve active medication administration. So interventions can that are non-pharmacologic can refer to some patients like to color for pain distress, or some patients will want to do artwork. There's a lot of different non-pharmacologic interventions that can soothe a patient: reading, listening to music, being able to play an instrument, stuff like that. Evaluation is based on the identified patient specific outcomes. So you guys should be familiar with these different words. As you can see, there is a nursing diagnosis, there's planning, there's implementation, there's evaluation. You guys need to be comfortable with what all of these mean. These meanings to these words, which is planning, implementation, evaluation, these are concepts and words you are going to also see on your exams. Exams as in like to become a nurse, the ESC and NCLEX. Desired outcomes depend on which nursing diagnoses are pertinent to the patient's situation. The degree of comfort obtained for the patient by the nursing intervention needs to be evaluated. So you need to ask yourself, how, as a nurse, can I see and evaluate my patient to make sure that I have obtained comfort at some level to them? So you need to ask yourself, what would I do to assess? What questions can I ask the patient? Do you feel comfortable? Do you feel relieved? Have I made things feel a little bit easier for you? What more can I do? That's part of you evaluating. What didn't work? Did I try something with you that you feel like it didn't make a difference for you? Do you feel any different from what has happened in the last few hours? I gave you a medication, or we tried to do yoga in the chair together. Did that make any difference for you? You need to evaluate what worked and what didn't work, and the compassionate nurse and the skilled nurse evaluates that client's needs and performs them and knows that that is something that helps. Physical signs of impending death. This is, of course, a very important slide. So that person is physically weaker, spends more time sleeping, body function slow, appetite decreases, urine output decreases, urine is more concentrated. Edema of the extremities over the sacrum. Pulse increases and becomes weak or thready. So we went over in my clinical class how to feel for a pulse. When you are noticing the signs of impending death, that is also a moment where a provider will ask you to observe the pulse and describe what the pulse felt like. Blood pressure will decline. So, those of you who remember what blood pressure is declining because the heart is not pumping as fast. It's not working as hard to supply blood because you're dying. The skin of the extremities are mottled, cool, and dusky. So it's not pink. It's not flushed. It doesn't look like there's life. Their lips will become more dull in color. Um, Skin will look pale. It will look like it is losing life. So you would expect somebody to look kind of dull. Respirations, they become shallow, they become irregular. So that means that is not coming at a normal pace. So I took note of the lips, and it's not noticeable here in the slide. It was not listed. Lips become very dry when a patient's dying. You will see it becomes very, very dry, and the mouth in general becomes very dry. You will hear the clicking of the mouth when the patient is opening it. So it is the nurse's responsibility to make sure that that patient is still getting proper oral care even at the time of death, and this also supports dignity at death. So either as a nurse, you will delegate this task for your teammate to help you out and apply like Aquaphor or Vaseline for the patient so that they are comfortable. You want to provide oral hygiene. A lot of oral hygiene at these stages come with a little sponge, a square sponge on a stick, and it's soft, and you just clean in, you clean out. Um, at the time of death, a death rattle is also heard. This is a phrase. It's called death rattle. This is heard, and it occurs when the patient can no longer clear the throat of their normal secretions. So I would recommend, if you get a second, also you want to write down and make sure that you have learned and understood the physical signs of impending death. This is very important. You will likely see this as well on your NCLEX or your HESI exam. Um, I also think the mouth care in death is very important. I don't know if it's going to come up in a slide moving forward, but this is something you also want to take note of, is mouth care and hygiene is still very valuable in these times. I want you guys to also remember what is a death rattle. What does it sound like? What does it mean? And then you're also going to take note of something called the Shine Stokes respiration. So respirations gradually become shallower and it's followed by periods of apnea. Apnea A in apnea refers to none or without, and apnea is breathing. So without breathing is no breathing, apnea. Um, as I said, I'm going to list or tell you guys what I think is important to remember from the slide is the slide number 33, physical signs of impending death. You need to remember how hygiene in general still should be carried out till the end of time, as well as mouth care. What is a death rattle? What does that sound like? And then what is the Shine Stokes respirations? What does that mean? What does that sound like? What does that look like? And what does that mean to me? Psychosocial and spiritual aspects of dying. As individuals approach death, their spiritual needs take on a greater importance. Do not impose your religious beliefs on dying patient and family. Instead, assist patients to find comfort and support in their own belief systems. Be aware of remarks you make in the presence of unresponsive patients because they do hear. This is also a great slide. This is real world nursing right here. Spiritual needs definitely come up when patients are dying or even for family members that are experiencing grief alongside. So spirituality might become very prevalent and important to somebody at that time. Um, a lot of nurses, or I will say some nurses, maybe not a lot, but there are nurses that kind of automatically will say, God is with you, or God is going to take care of you. I hope you go to heaven. I want you to go to heaven. I know you're going to go to heaven. You were so good to me. You've been a great patient. You don't want to do that. And it might feel so natural for you to say something like that. You need to stop yourself. And that is also part of therapeutic communication is allowing yourself to stop yourself from communicating a certain thing. Even if it feels like it's second nature to you, you need to stop yourself. Some patients don't believe in God. You don't want to put them in that awkward position or add to any grief or impose your beliefs because this has nothing to do with you and this has everything to do with the patient and their beliefs. So we don't want to include anything that is sensitive or considered religious. Um, Even remarks about the afterlife. Um, I'm not saying shut down any conversation if the patient is introducing this to you. So, for example, if the patient is saying, um, I hope I go to heaven or I hope I get to meet God. I'm excited to meet God, something like that. Of course, you're not going to, if you don't believe in God, you're not going to say, oh, well, that's not going to happen. You want to make sure you are validating them. That is your job. That is your role. That is what a nurse is. You don't have to agree with it, but you need to validate it as in you need to you need to be there for your patient and you need to comfort them and support them and be there for them. And validating, even if it's not your belief, can be as simple as you just listening. Um, Dying with closure is to say goodbye to the people and the things that are most important. A lot of patients will say at these times, I'm sorry, forgive me, I forgive you, and I love you. Um, You might also have patients tell you, because, death does also bring up a lot of familial trauma or, disagreements that have happened in families and friendships and stuff like that. Sometimes your patient will turn to you and they'll say, I don't know what to say to them. A lot has happened. I don't know what to say. I'm overwhelmed. I don't know how to say, I'm sorry. I did a lot of bad things to them. I don't know what to say. A lot of them, um, also will tell you I don't know how to say I love you before I go. I don't know how to express to somebody that cared about me, I love you. It's hard for me to say. I was never raised to say this. How do I do this? I need your help. This is why I'm trying to tell you guys communication is just so important as a nurse. I really enjoy being in psych. It helps me tap into my emotions a lot and it also helps me regulate how I speak to somebody. even in times of anger, even in times of firmness, even in times of sadness, even in times of joy, even in times of professionalism. You really need to gauge how you will be talking to somebody and how you will instruct someone else to communicate because they may be asking you, how do I do this? Um, I really like that it included here on the slide, which is something that I've also learned in my experience is um, guiding your patient to say if they are considering apologizing, I'm sorry, forgive me, I forgive you, and I love you. That's a good sentence to say and encourage your patient to say if they're having any difficulties like that. Um, Dying patients may exhibit confusion and disorientation, of course, because they're kind of floating in and out between the space of being here and not being here. So they might be confused, and that is normal, that's expected. Assurance that it is okay to go and that family members will take care of each other may ease dying individuals' anxiety about leaving their responsibilities. Comfort, comfort, comfort. Um, it is likely, as I said, that you are going to be in the room where all of this is going down. It's a very high intensity situation. I don't like being in this situation myself, but I have been presented with this quite a bit. Um, it's important for the nurse to be that supportive role, especially if you notice that there is no one in that room that is telling that patient, um, I'm here for you. I'm here for you. I'm still here. I'm here with you. You are going to be at peace. That we can say. That is not false that is not false reassurance. Um, this is kind of ties into hope. Hope is just that um, a better outcome is on the other side. It does not bring in any type of religion. And in these situations and these scenarios, when we're talking about end of life care and the process of dying, it is okay for the nurse to say phrases like this that are more neutral, as in like, um, I want you to be at peace. Um, I don't know as a nurse that I would tell a patient it's okay to go. Patients do appreciate hearing this as they are passing. It is true, but sometimes it might not be the best thing for you as a nurse to say because a family member might not like that you said that. So just be very mindful of what you say. And I do want you guys to note, um, be aware of remarks you make in the presence of an unresponsive patient because they do hear. So I don't know what you guys have been taught so far, but nurses are to assume, and there is some evidence that states that unconscious patients or unresponsive patients can still hear, even if they don't respond. So even patients that are in vegetative states or are nearing and inching towards death, you want to talk out loud with respect. You don't want to laugh inappropriately. You don't want to smile inappropriately. You want to make sure that your demeanor is completely appropriate to this situation. And whatever is said needs to be understood that that patient might hear you. Um, so please be very mindful of that. That is just honestly also on your character and on your values and on your morals. You should know better than to make any type of remarks to any type of patient that is unresponsive or even anybody with like a learning disability, any developmental issues, stuff like that. Any patient of any sort in any scenario that is unresponsive or cannot communicate to you the way that you are able to communicate, you do not want to ever make any type of nonverbal or verbal communications or remarks um, under the assumption that they don't understand you, because for all you know, they do. Um, so please treat everybody with respect. I would assume that most people know this, but unfortunately, there are some bad apples out there. So this is advanced directives. It spells out patients' wishes for healthcare when they may be unable to indicate their choice. Durable Power of Attorney for Healthcare. This is a legal document that appoints a person, a healthcare proxy, chosen by the patient to carry out his wishes as expressed in an advanced directive. So a lot of patients do choose a power of attorney for their scenario, and often is their family. A power of attorney is a legal document. So this was legally placed. If you do not acknowledge that a patient has created an advance directive and you have not acknowledged that a power of attorney was in place and that specific things were expressed for wishes, you can get in a lot of trouble for that. So when I'm taking care of a patient that I know is terminally ill, even if I don't expect that they are going to be passing on my shift that day, you just never really know. So if you know that you are taking care of somebody who has a serious illness, um, beyond even a serious illness, you really should always know this information. But when you are taking care of a patient with a serious illness, it should be on your mind to know what their status of a power of attorney is. Do they have advanced directives? And patients can also determine whether they are going to be DNR. If any of you guys know what that is, um, it is do not resuscitate. So this means I do not want CPR. You need to know that as a nurse. Is this patient DNR or not? You do not want to perform CPR on a patient that said, do not resuscitate me. This also happens in the hospital and also in long-term care facilities. And this is also, um, it's a little bit of negligence, honestly, from the nurse to not know their end of life wishes. You should know this. You should not be performing a medical intervention on a patient that stated they do not want this intervention. This is like kind of considered as if you gave a medication to a patient that they did not want or refused. It's also their choice to receive artificial feedings, fluids, ventilators, administration of antibiotics. But of course, everything that they are refusing or have stated to refuse, this needs to be documented. The nurse has to be active in keeping up to date because they might decide today that they wanted to be DNR, but yesterday they were not. They were okay with getting CPR yesterday. Today they might not be able to feel that way. So you need to make sure you're keeping up and reviewing this information on shift daily. Um, you must also deal with their own feelings and values regarding patients' choices to seek prolonging or death-seeking treatment. As I said, it's not always easy to take care of a patient, especially in their time of death, in a situation where you don't agree with how they're choosing to seek this out. You won't always agree with your patient. You really won't. It's just the truth. Sometimes you feel like your patient had more life to live and they didn't do it. And sometimes you will feel that a patient um, took the long road home when they could have ended it sooner and allowed themselves to go a little bit sooner and suffer less um, medical treatments that may interfere with their body and with their mind and stuff like that. So you're not always going to agree with what a patient has chosen, and this is also normal, but you need to tolerate your own feelings. Euthanasia, ending another person's life to end suffering with voluntary or um, without his involuntary, his consent. Passive euthanasia, patient chooses to die by refusing treatment. Active euthanasia, administering a drug or treatment to kill the patient, not legal or permissible. Assisted suicide, making available means to end the patient's life, such as a weapon or drug, knowing that suicide is their intent. So you're honoring the refusal of life-prolonging treatment of patients with terminal illness. It's legally and ethically permissible. Active euthanasia and assisted suicide are considered to be a violation of the American Nurses Association Code for Nurses. But if you guys have been reading in the news, um, there is a lot of people that advocate to open up the floor for more interventions for patients who do want to relieve themselves from suffering. So be mindful that things are changing and times are changing, so it might not always be set in stone that active euthanasia and assisted suicide would be considered a violation. But you want to at least honor the refusal of life prolonging treatment of a patient. Okay. Adequate pain control. Nurses advocate for compassionate end of life care, cornerstones of end of life care that can eliminate the need for a person to choose euthanasia or suicide. Knowledgeable and skillful symptom management, relief of suffering, promise of presence, of not abandoning the patients. Um, so physicians sometimes get nervous to prescribe pain medication for a dying patient. This can be because sometimes this is viewed or they are concerned about being viewed as prescribing lethal doses in an assisted suicide effort, which this can be true, and in some cases this is not true. But there is a culture around physicians giving the opportunity for pain medications to be administered where they are concerned about this. They do not want to over medicate so that it does kill a patient. Organ and tissue donation, organs that can be transplanted, kidneys, livers, hearts, and lungs, tissues that can be transplanted, corneas, bone, and skin. Physicians usually request organ donation from family members, but nurse may be in a position to answer questions the family raises about organ donation. So I do want you guys to take note of the organs that can be transplanted as well as tissue that can be transplanted. And how can a person be an organ donor? So you can wish to be a donor on your driver's license. And we also just discussed as well advanced directive. But the next of kin must give permission to remove organs or tissues of a dead person. Okay. This also might be another topic that is controversial for you. You may not feel that you agree with this, and maybe a patient wanted to do this. But as I said, you will have to just tolerate your inner feelings. So post-mortem, post is referring to after, and mortem refers to death. I want you guys, when you guys are reviewing vocab, look at the words broken down. It'll make things a lot easier. A coroner is a person with legal authority to determine cause of death. A death certificate is completed by the physician, the undertaker, and a pathologist if an autopsy is done. The nurse is responsible for post-mortem care of the body. Family members may assist with or perform the preparation of the body, or the nurse may prepare the body for the family to come say goodbye and for removal to the morgue or undertaker. So in a hospital or long-term care facility, physicians are typically the designated person responsible for saying the patient has been pronounced dead. When a patient dies at home, the pronouncement of death can be delegated to an undertaker, a registered nurse, or the coroner. What is an autopsy and who provides consent for the autopsy? So, an autopsy is an examination of the body, organs, and tissues to determine the cause of death. Consent for autopsy must be obtained from the next of kin, except in a coroner's case, when no permission is needed. So, which of the following is a clinical sign that a patient is close to death? Number one, increased level of consciousness. Number two, increased urine output. Number three, warm, dry skin. And number four, the Cheyne-Stokes respirations. I'm going to give you guys 10 seconds to review this question and then we'll come back. Okay. So your answer choice, we're actually going to go through every single answer that there is, and this is how you should be answering your HESI questions as well as your NCLEX questions. You need to go through each answer choice and you need to talk out loud to yourself why this made sense or why it doesn't make sense. You are talking out loud to yourself to provide yourself a rationale. The more frequently you do this, the better of a test taker you will become, I promise you. Even if you do not know the material to a question, the more that you practice rationale thinking in your head, even if you do not know the material, you will find patterns and your brain will start to do some pattern recognition on exams, and there will be an influence in your exam scores, I'm telling you. So, which of the following is a clinical sign that a patient is close to death? One, increased level of consciousness. I'm going to answer this as if I was a student. That can't be true because if my patient was dying, there's no way that they would be more alert. That doesn't make sense to me. I'm not going with number one. Number two, increased urine output. Increased urine output. So that would mean to me that the body is working. The body is working hard if it's increased. The body is not working in depth. So that can't be true. There would not be an increase in urine output because your body would be slowing down. It would not be moving faster. So I know that that is not true. Number three, warm and dry skin. So if a patient is dying, they are losing their oxygenation from the blood. So they will not be warm. The blood is not giving the warmth to the skin. It's not giving the color to the skin. Warm and dry skin is seen in normal patients. You would see, like I said, dull skin, skin that is without life looking. And then number four is our correct answer, Cheyne-Stokes respiration. This is a clinical sign of impending death. Other signs of impending death can include decreased level of consciousness, decreased urine output, and cool, mottled skin. If you guys can't already tell, the Cheyne-Stokes respirations really needs to be studied and understood. This is also a concept that you will see lifelong as a nurse, and you will also see this in exams as well. Okay, we are almost at the end here. Maryland's hospice patient refuses treatments that might prolong her life. She is refusing IV fluids and antibiotics. This is an example of number one, euthanasia. Number two, passive euthanasia. Number three, active euthanasia. Number four, assisted suicide. So for this answer, I'm not going to go over the line by line of everything. I want you guys to attempt this to yourself. So I'm going to give you guys about 20 seconds. I want you to go line by line, and you need to tell yourself, if I don't know what any of these answer choices means, that's how I know I have a knowledge deficit, and that's how I know I need to write this down. Okay, so you should have chose answer number two, passive euthanasia. This is when a patient refuses treatment that would prolong their life. You should have been able to define number one. You should have been able to define number three. And you should have been able to define number four. I can, of course, go over this with you, but I'm going to turn the responsibility back on you. If you did not know any of these answer choices, you need to write this down and understand it. Lastly, question number five, which of the following patients would be ineligible for organ transplant donation? Number one, 8-year-old brain dead patient on a ventilator. Number two, 16-year-old cancer patient. Number three, 47-year-old who died of pulmonary embolus. And number four, 30-year-old automobile accident victim. Take a second to answer that question. You might not know the answer to this, and that's okay because it was also not provided in the slides, but this is really how NCLEX questions come about, which feels unfair, but it's just kind of how it is. So look at all the answer choices and think to yourself, is there one that looks like an outlier? That is how you really answer questions, particularly too when you don't know or didn't get to review a concept. So to me, I would have red flagged number two, and I would have also red flagged number three. Between number two and three, I would have gone with number two because cancer is a disease, and cancer affects your organs. So you want to think about that. You need to kind of be critical in your thinking and think about what does cancer really mean versus what does a pulmonary embolus mean. Okay, that is the end of this lecture. So I hope you guys review everything. If you guys have any questions, please feel free to message me. If not, please make sure that you have worked on all of your assignments from week 1 and week 2 in your theory section. You also want to make sure that you completed week 1 and week 2 in your clinical section. Those are two different sections. So there's different assignments for each. It's very confusing, but you need to make sure that you are responsible at this point and you are completing it. And I hope you guys have a great day. Thank you guys for listening.